All right. Excited. State of the Union in dentistry. Really
Yeah.
excited to have a couple of my guests on today. I figured, State of the Union, we got to bring in smart people. So let's bring in these two smart people. We have two board certified oral surgeons that are from Ohio State. They're Ohio State grads. So before you Michigan guys, turn this off, I just want you to know that they don't care about football or basketball or Michigan or Ohio State's rival, right? We can't hear you, Rob. I don't know. I'm not sure. I'm sure we'll get that fixed in just a second. But Jason, Dr. Jason Yanich, thank you for being here, my friend.
Yeah, thank you for having me.
So Jason's been following me for, I don't know, we couldn't decide how long, but he's been following me for a while. And, I troll the social channels, and he was saying something about, I don't even remember what he was saying. I'm like, hey man, Jason, it's time for you to come on. Cause he always makes fun of me on the social channels. And I figure, you know what? I'm going to get his ass on my show. So I appreciate you. I appreciate you being here, man. Thanks for doing this.
Yeah. Thank you.
Rob, are you fit? Are we good?
Yeah, I think I'm ready. I said earlier I didn't realize Michigan had a football program.
Yeah, that's right.
Did they get one?
That's right. Yeah, I mean, listen, I'm a soccer guy, so I don't know much about football, but I do know that you guys have a little scuffle going on every couple times a year. But I appreciate you for being here also, Rob. So Rob, it's his third time on my show, on my live show. So Rob, I appreciate you doing this. And
Certainly.
And, I figured we got to do something for Rob, considering that he's putting all this time and effort in. And so I thought of an idea. I think he actually probably brought it up. Maybe you want to show him what we were talking about, Rob.
Well, I have received this fantastic hat here.
Look at that, man.
Which, living in Oklahoma, this is like, you got to have one of these things, right?
It's awesome. You look great, man.
I ride a horse to work every day, so I may as well have the hat to go with it.
It looks great. So, so being a veteran of the live show, I figured we got to have some type of a gift for my guests. So I appreciate doing this, Rob.
It's very nice, too. High quality. I mean, there's no...
yeah, it fits you well, man.
Out.
I couldn't figure out how big your head is. You oral surgeons, like I didn't know, how, if I was buying the right size or not, but yeah. So thank you for being here. So I was talking to Jason earlier this week, and then we were talking earlier today, and he sent me this photo, and I was like, you know what? Like, what percentage of dentists actually need this? If Tori, you want to show Elon's photo? What percentage of dentists actually need to go through dental school with a little smoke, right? What do you think that percentage would be if you were to guess? I mean, I would say 15%.
I think they were doing a little more than smoke when I was in school.
So I appreciate Jason for sending that photo this morning. Look, I'm intrigued because I'm in the front seat of some great conversations, and I think it was either last week or the week before, we had a couple of oral surgeons on, and we had a discussion about the decision of when to have a patient be safe in a general practice and an oral surgeries practice, or have to move the patient to the hospital. And so that conversation created some engagement on social channels. Tori, do you want to play that video with the oral surgeons from a couple of weeks ago?
I'm going to interject just for 1 second, because I think from the standpoint of what Ryan just said is absolutely critical, because ultimately, from a medical legal standpoint, if you're doing surgery, you're held to the higher standard. So you have to practice that way. Listen, I have patients, just as Ryan does, that come into the practice. We have to make a decision at that point. Can this be treated in the office, or does this have to go to the hospital? And that hospital part of the formula equation doesn't even exist in the hands of a general dentist. And the fact that they would implement or attempt to do a procedure, they don't even know if it should go to the hospital sometimes. And it's scary. And the person that's at the disadvantage of it is the patient, and it could cost them their life.
Yeah, so it brought up the conversation on social channels about ambulatory surgical centers. And it was interesting because, quite frankly, I wasn't aware that this was something that's really popping up in many locations around the country as kind of an in-betweener of not necessarily taking the patient straight to the hospital. And that creates an opportunity for the general dentist or oral surgeon to have maybe, if I can use this term or word, a safer location to treat these patients. And I thought this would be a great way to start the conversation today. What are your thoughts, Jason, on an ASC in our profession?
I think the same argument that last surgeon was making about the general dentist, I think still holds true. There still needs to be that deciding factor of, is this something that should go to a hospital or could be handled at a surgery center? I guess my opinion on it's a little different. And Rob, I don't know what capabilities you have in your office, but I kind of treat my office like it is an ambulatory surgery center. I mean, we have full general anesthesia capabilities. We have, full anesthesia machines. I do know that there's some oral surgeons that I would say practice with those smaller, like portable units that can deliver nitrous oxide and oxygen, but maybe don't have, the full ability to intubate and ventilate like maybe a surgery center does. So I guess my opinion is a little different because I feel like I work in a surgery center. So when somebody's really sick, that's when I know that, okay, we're going to the hospital. And that's pretty rare that I go to the hospital.
So you think that your location where you practice is like an ASC location? And
I would say it's outfitted like one. It's not in the fact that I don't have, a dedicated anesthesiologist and nursing staff that is doing that as well.
Interesting. What about you, Rob? What are your thoughts on that kind of an in-between location for these patients?
Yeah, I actually take advantage of that myself. Usually, because we do quite a bit of corrective jaw surgery, and one of my offices happens to be literally across the street from a hospital. So the vast majority of those patients I treat in that particular hospital. However, sometimes I'll have a patient whose insurance just does not want to play ball. And you can then go to an outpatient surgery center, an ambulatory surgery center, where the patient can get a more favorable financial package available to them. And there are fewer question marks. And what I mean by that is taking a cash patient to a hospital is a dangerous game to play in terms of what bill they may receive after all is said and done. The ambulatory surgery centers are very good at telling patients up front with full transparency, this is the cost that you will pay for using this facility, and that typically includes the anesthesia as well. It's minus my fee, which we obviously have told them already. So the patient isn't going to get stuck with some $500 Tylenol tablet times 6, for no reason whatsoever. So I use them. I think it is valuable, and there's definitely a place for them. Patients that are ill, like significant medical problems, my preference is to use a hospital in the event that we run into an airway problem on extubation that may require an intensive care unit night or some sort of other subspecialty consultation. But again, that doesn't make a surgery center a wrong option for those patients. That's just how I go about it.
So is it fair to say, well, I'm learning as we're having this conversation. So when you take them to the ASC location, are they using any kind of insurance? Can they use any insurance? Is it a cash environment? And what about the hospital setting?
It is both. You know, there is the offering for the surgery centers to use the patient's insurance. And of course in the hospital as well. But there's one in particular here in Oklahoma that's literally quite well known throughout the country and beyond, actually, for pioneering the cash patient fee schedule, which they actually post on their website. So patients literally will shop for their surgical center and see that and know, if I'm having X procedure, this is the cash price that I will pay, period. And that's their model. That's what they use.
What kind of, so in essence, they already have the business model in place. They know what the fee is. It's a set price. You walk in, the patient knows what's going on. There's no surprises. And what about a general dentist's ability? There is no anesthesiologist at these ASC centers, or there is?
I would say there is, yeah.
So if there's an anesthesiologist there, that's included in the pricing for the patient, so the doctor doesn't have to have that as a quote in their location for the service. So it just becomes, for example, an all-on-X service, whatever that fee is, plus whatever the fee would be for the ASC location, correct?
Correct.
Yeah.
And how they do their pricing is, let's say, for example, I'm going to go do a jaw surgery. They will essentially look to see what supplies the hospital will need to use to accomplish that case. So how many nurses will it require? How long will the anesthesia likely last? Will the patient require an overnight stay? What type of disposables will be used during the case? And that is essentially what they use to set their, and then they take that all into consideration and come up with a price.
So in corporate dentistry, you have to have a licensed dentist working. Is there any licensing restrictions for these ASC centers, or could it be just privately owned by somebody outside of the dental profession with no license?
I think the majority of, and I don't know the law on that, I don't, but I think the majority are physician owned, and they will have a credentialing committee is what they would call that. So in order to use the facility, you would fill out a credentialing application, which would have all of your credentials, obviously, that they would review and make a decision as to whether you're an appropriate candidate to perform procedures there. They would look at the procedure being performed, the proposed listing of procedures. And also, by the way, there's a thing called core privileges that we look at in hospital settings and surgery center settings. And essentially what that means is, let's say you're a general surgeon. As a general surgeon, these are the things that you are likely to be performing. And those would be the most common procedures that a general surgeon performs. Gallbladders taken out, et cetera, colectomies. So you would acquire what's called core privileges. And the committee would look at your training and ask, has this person gone through a general surgery residency? If so, where? And whether letters or recommendations stating. Now, you may say as the general surgeon, but I would also like to perform procedure X, Y, or Z, which falls outside of the normal procedures for a general surgeon. So you would have to list those procedures separately and then provide supporting documentation that you have performed X number of those, and in what setting did you do so, and when were those performed, and what training did you receive to perform those. And they will then evaluate the appropriateness of you gaining privileges to perform those as well. And they may deny that if they're not happy with your credentials.
Yeah, the other thing that I found out through the conversation, and I think it's worth discussing, is that I didn't know that general dentists have hospital privileges also, where they can do some surgeries in a hospital setting. I'm assuming you both were aware of that, but I wasn't aware. I thought it was just mostly surgeons that would get that privilege to go to these hospitals.
Yeah, I think it's more rare, but it does occur. Particularly ones that have gone through GPRs, then they would be more likely to have hospital privileges.
So I was talking to Jason a little bit before we started here, and he had a kind of an interesting story on how he ended up becoming an oral surgeon. And it got me thinking about dental students and well, maybe Jason, maybe you want to share a little bit about what you were going through as a dental student and your journey on how you ended up being an oral surgeon.
Yeah, Rob, I don't know if you know this either, but when I went to dental school, I went with the intention of becoming an orthodontist. I really entered dental school thinking that I did not want to be a general dentist and I wanted to specialize. Mm-hmm. And, when it was time to get to the clinic floor, like during third year and fourth year, I really worked hard to spend a lot of time with the orthodontic department, and actually had some dental school patients that were also ortho patients, and I would take them to the ortho department and do place brackets or do adjustments and those kind of things. And my goal was to get into the ortho program, and I applied. And again, I guess I didn't realize that getting into dental school was competitive, because when I applied to dental school, I only applied to Ohio State, and I got in. And so when it was time to apply to ortho, I knew that I really wanted to go to that program. Buckeye, through and through. And so I applied to Ohio State only. And I was actually going through my my interview day. And, at the time they had, 11 or 12 different faculty members that were all doing interviews. And I went through 3 or 4 interviews. They all went pretty smooth. And I got to like the 4th one, and it was the program chair. And he asked me a couple basic interview questions. And then his next question was, well, do you know why you're not getting in this year? And it was just like a gut punch. I was just like sickened by it. I'm like, what do you mean I'm not getting in? And he's like, you're either really stupid or you're really cocky. So which is it? And I was like, what? Like, I had no idea. And he's like, where else did you apply? And he already knew. I mean, like they know through the match program, like where else you've applied. And I said, this is it. I've only applied here. And he's like, I know. He's like, I knew that before I asked you. He's like, that's why I'm asking. Are you cocky or are you stupid? And I had no idea. And he's like, it's really competitive. The whole point is to go through the match and go see a bunch of different schools and have those schools rank you and you rank those schools. And then that's how it, like, just like a dating app, like that's how it picks the best fit of who you should end up with. And he's like, you're our number one pick if you come back next year and do this again. But he's like, this year, we're not going to take you. Like, you're going to have to do it again. And that's how I ended up doing a GPR. And, the plan was just to do the GPR and then reapply to ortho the next year. Like, actually, by that point, it would have only been, several months later. I'd have to be getting those applications put together again. Mm-hmm. And once I got in the hospital setting, I just fell in love with the hospital setting, with the OR, with, seeing medically compromised patients and all the other stuff that, as a GPR you get to do. I mean, you can go down the trauma bay and hang out, or you can go in the ER and hang out and do all kinds of procedures and not dental procedures, and got really excited about hospital stuff. And then so that changed my whole trajectory, and I decided to, refocus and apply to oral surgery.
That's a great story.
Yeah. So, so now kind of put yourself in a dental student's place, Jason. Like, what are you thinking during this time of I'm making a decision on what I want to do? I mean, in fairness, I think dental school doesn't necessarily teach you. By the way, it's pretty cocky of you to just apply to one dental school. I just want to share that.
Yeah, I had no idea.
I didn't know. I don't know if you were cocky about applying. Well, probably. I don't know if that was cocky.
I'd say I was probably more naive and stupid that I did that.
Well, I tell you, I applied to like 28 schools because I was just, rolling the dice, and I'm like, all right, somebody's going to take me, right? I actually applied to 28 dental schools prior to taking the DAT. I had my MBA and I was like, all right, I'm going to give this one shot. I was 29, 27, 28. And you know, you graduate college, you're 22, 23 going into dental school. So I'm like, all right, I'm kind of be a little bit older. I'm going to give it one shot. And then I ended up getting a 22 on my DAT, and you know, which is a pretty good score. And then I got a lot of interviews, and I decided to go to Tufts. But yeah, it's an interesting story. But I do know that when I talk to students, many are confused.
Mm-hmm.
Many are confused whether they want to go to dental school. We'll have that conversation on another show. But many are confused in dental school as dental students on what's next for them.
Mm-hmm.
You know, do I go to GPR? Do I do a 1-year residency, 2-year residency? Do I go straight out? I got all this debt. Do I go into residency and specialty? And I mean, some of these specialists are coming out with over $1 million of debt. I mean, we're complaining about $400,000 or $500,000, and you know, orthodontists are graduating with over. I've talked to them 1.2, 1.3 million,
Wow.
and you know, so what's your frame of thought on, you know, how, well, maybe you don't need to say, but were you heavy in debt when you graduated? And, you know, was that a consideration?
You know, it wasn't too bad. I don't remember exactly like what my dental school debt was, but it wasn't bad. Maybe like 100 some thousand, probably under like 200,000. But again, this is 30 years ago.
You're cocky, you're bragging. Come on, 100,000, that's it?
But
Jeez.
But you know, the thing during and Rob, I don't know if this was the same for you, but during residency, we got paid. So we were actually paid a stipend, and that really helped. So if you were still living like a poor college student and using that stipend to pay down your loans, it really wasn't that bad. I think the issue is a lot of those residents, you know, they're out living like they're a doctor, and they're driving the nice cars and living in nice
absolutely
apartments. And I don't, you know, they're not planning ahead that they have all this debt that's just continuing to build up. So
yeah, it's like there's this silent crisis that's being manufactured in the lives of dental students. And then at some point, I think a lot of them kind of figure out what's happening. In other words, they start to understand that this is coming to an end, this being school.
Mm-hmm. Yeah.
And then they switch into this mode of, you know, I feel like young dentists are overwhelmed by debt. And so they start optimizing their life for survival rather than fulfillment. In other words, you know, we are looking at forming this wonderful career, and we have these visions of grandiosity of becoming a dentist and yada, yada, yada. And then it's like, whoa, they're looking at their debt thinking, wait, I'm now going to have to start paying this off. So you ask, what are you planning to do? And I think I may have mentioned this on a previous show, but I saw 2 dental students in the operating room. This has been a year or so ago, and they were there to observe another doctor. And I said, what are your plans up on graduation? And they said, well, I'm going to be looking for a job. And I understand what they mean by that, but they really meant that. Like, I'm looking for a job. And I said, well, where are you going to look for a job? Probably at a corporate office. And that was the extent of their plan. And I said, what about owning a practice, or what about buying a practice? And the answer there was, and quite literally, verbatim answer nearly was, we don't even know where to start to do something like that.
Mm-hmm.
And, you know, I love the fact that they're looking for a job in terms of, you know, looking for a practice to join, but pick a good one. Join a good one. Join a practice that has vision and direction and branding and is something special. instead of settling for someone who basically peddles a commodity.
You know, it's such a discussion, the confusion of dental students getting into the workforce, the inability for a 23 or a 24-year-old to make these, you know, major decisions, which is really, if you look back 25 years later, it's not that big of a decision, but at that time it feels like something, you know, it's like I have to make this correct decision. And then they get into these corporate contracts because they're almost forced into it. It feels like they're almost forced into this situation where now they're in a contract they can't get out of. So I think there's a lot of uncertainty for these fourth-year students, and that's why I was kind of intrigued by what Jason was telling me prior to the show, about, you know, kind of how he had to kind of go from ortho to oral surgery. I think, you know, for me, it was very simple. I was 13 years at that time in school, 33 years old, and I didn't even think about GPR or specialty. I was tired of school.
Mhm.
You know, I was just tired, and I wanted to get out and start working and start going my own path. And, you know, quite frankly, now looking back, getting into military agreements of doing 2 for 2 or 3 for 3 or 4 for 4, I got out with $400,000 of debt at Tufts, and I lived a little bit more lavish. I guess I had my own single apartment, and I paid 4 years of living on my own. I guess I could have lived with 3 other roommates and, you know, cut 50, 60 grand or whatever it is off my total debt. But I decided not to do that because I didn't want to party and whatever dental students do. I had to actually study because I
Mhm.
was a business major in college, and I played the pro sports for 4 years. And so biochem for me was like dental school for me was work, where for you guys, it was like the 3rd or 4th time that you probably seen the Krebs cycle, you know. And
I'll tell you though, I was similar. I found it to be something that I worked at. It was a full-time job.
Yeah.
Yeah.
And I felt the pressure of always needing to overperform. And that started in high school, really, because I decided that I wanted to be a dentist in high school. And so, you know, I wanted to get into college, and then you get started with college, and, you know, I wanted to get into dental school. And so I knew, I got to get good grades. And then you get into dental school, and, you know, I want to get into a residency. So now I got to get good grades. And
Yeah.
it just never ended.
Yeah.
And then I was in residency, and I thought, now I got to pass my boards. And it's just this cycle, 12 years of working at being a student, which I signed up for it. So,
well, I can tell you it, you know, and I'm just using this as an example. I'm saying this is across the board, but there was a lot of ass kissing for the guys that wanted to get into specialty programs at Tufts. And, you know, they definitely try to get into the minds and the heads of the heads of those departments rather quickly, whether it was perio or ortho or surgery. So I thought that was kind of interesting, the competition of how you can finish as the top 10 student versus mood. Didn't give a shit. You know, I was just like, man, I just want to get through dental school, you know. But definitely there was, you know, the top 30 guys, 35 students, you could tell that they're competing. You know, you could tell that they're competing for grades, they're competing for position to get into residency, which I thought was rather interesting. By the way, I don't know if you guys noticed, I just noticed we're like all wearing pretty much the same freaking color, man. That was not planned. I just want to say, like, we don't have uniforms for these shows. It's just dress as you like is what these shows are about. But it just happened that, you know, we're all dark complexion guys, and we figured, hey, we'll go a little dark today with our shirts. So Rob, the very first time he came on, he wore his coat, and I was like, damn, dude, easy with the, you know, I'm an oral surgeon. and he was sitting a little bit taller than me, and I was like, "Holy, all right, whatever, man." No.
My staff actually were joking with me. They were asking what I was going to wear, and I told them I have no idea. I'm going to go home and dig through my closet and pull out whatever's less wrinkled, and that's probably what I'll end up in. But they're like, "You're not going to wear your white coat?" I'm like, "No." But then I remember I actually did see part of that episode where you had the white coat on. So
I may bring it back out.
Well, I tell you what would look good: the white coat with the cowboy hat, dude.
Oh,
That's
yeah.
it. That's
right.
That's the combination right there. I was talking to and so what's the summary of this discussion with students, right? I mean, I think the key really is it's okay not to know the answer.
It's okay not to know the answer, but just really don't settle though, just do something good.
Rob, do you get a lot of dental students that shadow, or do you have any shadowing opportunity?
None.
Because I will tell you that I've had a couple come through. I think I've had 2 or 3 that have came and shadowed me, and really eye opening for them to see the day, what a day looks like for an oral surgeon. And again, I'm not doing the big cases that you're doing. I'm more bread and butter. I'm doing typically wisdom teeth and implants. Like today, normally on a Thursday, I don't do an all surgery day, but today was an all surgery day for us, only because I had a CE event that we went to last night. And so we started actually late. We started an hour later than we normally do, but we did all surgery. I was done by 3 o'clock, 3:30, but we did 8 sets of wisdom teeth, a couple local,
great days.
And I had a couple implant cases too. So, but
yeah, those are, well, I had an interesting experience today. This is off topic, but you brought up wisdom teeth. And I guess this fits into the general dentist doing surgery category, as far as what can happen. This lady, I'd actually seen her probably 10 years ago, at which point she would have been in her 70s. And she wanted to do orthodontic therapy, and the orthodontist asked me, of all things, to take her canines out, maxillary canines out, because they were way, way, way out facial, and she had tons of crowding. So I did, and he made her look great occlusion, great aesthetics. Fast forward 10 years, and she has partially erupted number 32. It's not really erupted, but it's breached the gingiva, and 31 has caries. So I took out 31 and 32 today. And I said to the girls, I'm going to take 31 out first, and then I can just kind of sneak 32 out because there'll be an opening there. 31 comes out. I section 32. I mean, I looked at number 32. I hardly even touched it. And Krzak, mandible fracture. Second one I've had in my career. So I did a little anterior border wire on it and sent her on her way. But that was my wisdom tooth story for the day.
Yeah.
It's actually, I mean, honestly, when I first started my first 10 years, I was taking out wisdom teeth, and I knock on wood. I mean, seriously, I didn't understand anatomy as well as I thought I should have understood anatomy. And I got lucky. I didn't do full bonies, but definitely soft tissue and partials. And, you get in there and you start cutting shit and you don't know where the anatomy is. So it's and this is the discussion I wanted to have with both of you as well. Tori, if you can show the first about 2 minutes of this video that Rob was talking about with his white coat.
So when it happens, and it will happen when this disaster occurs, have you developed meaningful relationships with specialists that you can trust, that are not in another state? And honestly, there's no reason for that. No. You should, and so how do you do that? That actually now becomes a valid question. If I get a phone call from someone, I don't care if it's a general dentist or a prosthodontist or whoever it is, and they want my help, I'm inclined to help someone. But if someone phones me who I have a meaningful relationship with, and this is going to sound very selfish, but who also refers normal patients to me, I will trip over my feet to help you. I will run to the telephone, take your phone call. But just to be really frank about it, if I get a phone call and it's just someone that I've never heard of and they've got this awful complication and they need help, I'm probably not going to trip over my feet. And that sounds so selfish because the pushback that I'm going to get is, yeah, but you're an oral and maxillofacial surgeon. You're obligated to help me. I'm not obligated to help you. Just like you, and just like any other practitioner that practices anything, I get to choose my cases as well. I get to choose them. And perhaps before we choose to embark on a case that perhaps is outside of our skill set, we should think about that.
Well, you know, and David, you're right. We're going to touch on
Nice beard, Rob.
Salt and pepper nowadays.
That was a lot more of a close up than we wanted. But here's the conversation that I want to have, and I believe this might have been, Jason, why we kind of got into that conversation and why we ended up here is this referral system. And you know, I've heard. I talked to Dr. David. And he was on our first show and prior, and I was going to talk about it then, but the horror stories that you guys have with, I mean, look, and I know there's a certain level of respect, and I get that, but let's just have a conversation here, right? Because what percentage of your day is dealing with the bullshit that you get from GPs on a regular day? Is it a big percentage? Is it a small percentage?
I don't think I wouldn't call it a large percentage, but it, you know, when look at it from the different perspective though. Don't look at it from our perspective. Look at it from the patient perspective, because it may be 5% of my practice, but it's 100% of their life.
Yeah, exactly.
Right? And that's really what we should be looking at. Not is this a burden to me or is this a burden to the dentist? It's, wow, really? Did you really do that? It's a problem.
Yeah, you know, and the thing is too, is that a lot of those patients, maybe at the time, they don't know. And I'll take something like really simple, like say, for example, the person that comes in and they're just referred for wisdom teeth. We'll go something easy, wisdom teeth. You look in their mouth or you look at the x-ray and they've got 17 and 32 and they're, you know, they're ugly looking. They're, you know, distal angular, they're horizontal, they're close to the nerve, but you see 1 and 16 are missing. And then you ask them and they're like, oh yeah, well, my dentist just took those out like a month ago or 2 months ago. And then, you know, you go through the process of like, well, here's all the risks and here's what we can do. And, you know, you consent them to go under, you know, whether it's deep sedation or general anesthesia, and you're going to take those wisdom teeth out. And then that's when the light bulb goes off for that patient where they're like, wait a minute, I could have had 1 and 16 out at the same time and I could have been asleep. But instead I suffered through like a 2-hour procedure where my general dentist did it. And then they sent me to you anyway for these other ones. And that's where like they start realizing like, oh, I could have just had this all done like under an hour and I could have been asleep for it. But instead I stayed awake. And then that's when then you really see the wheels going like, why did that happen? And it's like, oh, it's the financial implications of it. And yeah, it's really unfortunate for the patient that they go through that.
So Dr. David Wong told me, and I hope he doesn't mind me sharing this, but he told me that he literally would get referrals where the general dentist would request to have the tooth extracted and then sent back for the grafting to be done by, and I think I'm saying this correctly, the grafting to be done by the general dentist. I've had endodontists tell me that the referral GP is requesting the file that was separated in the canal to be removed, to be sent back to the patient, to the doctor, to have the root canal completed. I mean, it's, do you guys have a couple of these crazy, I mean, look, you guys are obviously seasoned, but just look back into your first 5 years of practice and your relationship building process with your referral source, which is the next topic I want to talk about, direct to consumer. But, let's talk about this, initial phase of you're meeting now your GPs in your community. Do you got one or two of these types of stories of, just kind of a head scratcher type referral?
Yeah, it's definitely, I've had the, take out the lowers, but leave the uppers for me referral regarding wisdom teeth. And I don't, by the way. Once I have them, I'll do what I want, do what the patient wants. I just don't play that game, and I don't respect that at all. I have I'm going to refer nothing to you, but once a year, I'm going to call you and ask you about this bizarre pan oral ulceration thing that I would like you to see. No, thank you. Not going to see that. And my line to them is, why don't you send that to the person that you normally refer to, which is yourself?
Yeah. What about you, Jason?
Yeah, so I'm going to echo what he has said, is that, again, when it comes to those relationships, and Rob, you might have to correct me on this one, but the A, B, C, D classification of like your referral, like when they talk, oral surgery referrals, so basically, and general dentists probably won't know this, but if you go to some of these conferences and talk about marketing and referrals, your A referrals would be like the people that Rob said, the people that send him the good stuff and he's going to trip over his feet trying to help them out. Like, that's your A's. And then B's are like a little bit less than that. Maybe they send you some good stuff, but not routinely like 100%. And then I get lost in the C's and D's. D's basically like you're not even going to talk to them. Like you've never heard their name. They're not on your radar. And C's maybe like you've heard of the guy, but you don't really get referrals from him. I would say that, again, we don't want to get into the referral part of it just yet, but I don't feel like I really have good A's and B's anymore. I feel like that stuff has kind of dried up, and now it's just, I see what I see, but I'm going to say that I think I'm seeing the harder of the stuff. And you still get those calls where somebody wants to get bailed out. They've taken out a number 14, and now there's maybe. The best is when they're like, maybe there's a root in the sinus. There's always this thought of like, I think I got it out, but there's a hole, and maybe there's a root, maybe not. Like, will you see this person and close the hole? And those are the kind of like things that you get every once in a while. And luckily, I think probably like you, Rob, I've probably made a name for myself where those people don't necessarily bother me with that stuff anymore. I think they know I'm going to say no to it to begin with, so we don't see a lot of that.
Yeah, it's interesting because we had a discussion about complications with Rob on another show, and this whole discussion about complications, and now you're talking about seeing these C's and D's, and in the GP world right now, there's and we talked about this too. There's 22 states that consider general dentists to be board certified implantologists. And so, which by definition means they went to a couple of, these programs, and I'm not trying to belittle these programs. They're a lot more in depth and vast, and some of them take a couple of years to get these, to become a diplomat or a fellow type of programs. But this debate on, 80% of oral surgeons are doing wisdom teeth extractions, and all I do all day, every day is place implants. So, I'm more qualified than an oral surgeon to be placing implants, to be doing all on X, and to be, I'm a general dentist. I'm a restorative dentist, and to restore these cases. And I find it interesting as these discussions are now leading into these C's and D's, where Jason's and Rob's are now going more direct to consumer. And it's like, I don't want the C's and D's, right? I can just go and, go direct to consumer. Why do I need the C's and D's to call me at 5 o'clock when I'm going home? Where are you with your business plan today when it comes to direct to consumer versus maybe even 5-6 years ago?
We made that decision probably in 2015 to put a major emphasis on that. And the impetus for doing so was having a doctor that was an A retire, sell the practice, and then that completely goes away. So that practice is now owned by typically a young male dentist. Female dentists tend to maintain really good communication and relationships and are great referral sources. So once we started noticing that happening, we kind of got on the marketing train, and it was not very long into that Google became a very large referral source for us, and we've been doing it ever since, and I'm glad we did, because that's what you need to be doing. It's very important. Now, having said that, I would call us very fortunate to live and practice in Oklahoma, because it really is a great place for dentistry. We have some fabulous, really great dentists around here that are still in that A, B category. And again, I'll do just about anything for them. I think it helps that we have a dental school here, and half of the graduating class are again, females. And again, they just tend to want to collaborate more. We get great questions from them, great communication from them. A lot of comprehensive treatment planning goes on, group effort, teamwork, that sort of thing. But like I said, Google, and now, of course, other platforms, social media, it's super important.
Mm-hmm. Yeah.
What are you doing with it, Jason, as far as direct to consumer?
So I've always done that. Like I said, I got out of residency and went into practice in 2007. And, at the time, things like Facebook were still pretty young. But I was always big on the fact that we should also be advertising direct to consumers, right out of the gates. And some of my, at the time I had older partners who were not interested in that. But I still managed it myself. I would just set up my own Facebook page for my business and run that myself, because I still wanted to, like you said, brand recognition. I wanted my name out there. I wanted my brand out there, and I wanted people to be able to find me. The other thing that's a little different about my practice than maybe Rob's, and I don't know, you could tell me I'm wrong, but we take, I think it's like 30 plus insurances that we work with, and we work with not only the regular ones, but we also work with state funded, Medicaid, Medicare. And so there's a lot of patients who just look for who's in network, and they're going to find you. And, I have patients who find me from 2 to 3 hours away and come to me because I'm the only guy in half the state of Ohio that takes that insurance. So that, again, the referrals have become kind of much less important, because the patients are going to find me either way.
Which is interesting, because now you could be a great referral source for these general dentists right? Yeah. And so now you're kind of like in this bind of, I hate this guy, I don't have any A's, right? Or maybe you don't hate the guy, it's a strong word, but what do you do with these patients? Are you, is there a certain level of, and I'm just brainstorming now, but you would think that what's wrong with bringing a general dentist into my practice? Mm-hmm. There's a combination of general dentistry and perio. I mean, the general dentists bring specialists into the practices all the time. Why not you guys?
Yeah, my staff and we've actually talked about what that would look like. I mean, there's always a fear that if you had a general dentist in-house, maybe some of your referrals would be less likely to refer, because they would be afraid you'd poach their patients and not send them back. But it's interesting, like you said, as far as us being a referral source back to the general dentist. I get a lot of patients who come to me that maybe they're just missing a tooth or a couple teeth and they want an implant, and then I talk to them about the fact, well, I don't restore them, so somebody's got to restore it. We need to get you set up with a dentist, and that's when they say, well, I don't really have one. I haven't had one in 6 years or 7 years, and then to look at like my community and say like, okay, well, these are the 3 people I would say go to them or try them. And then find out a lot of those practices, maybe they're already busy and they're not taking referrals. And to me, that's crazy to say, like, I'm sending you an implant patient and you're saying you're too busy for it. I mean, all you got to do is take the impression and seat the crown. Like it just doesn't, to me, maybe I'm wrong, but to me, that doesn't seem like a lot of work to get paid for a crown.
Well, there's oral surgeons that are restoring their own implant crowns. There's oral surgeons that are restoring their own all-on-X cases. I mean, at the end of the day, you guys are general dentists.
Yeah.
Right? And so there are now periodontists, oral surgeons that are doing their own all-on-Xs and restoring their own all-on-Xs with prosthetics, digital workflow. They're getting into these courses. They're getting into these programs. Have you guys thought about maybe just taking on the restorative side?
I've thought about it, only thought about it. Now, what I will do and do a lot of are temp crowns, just to form the transition zone around an implant. And then for all on X cases, I carry the patient up to, I think tomorrow I'm actually putting in a temporary prosthesis for an all on X. And I'll carry them up into the torque test. So implants go in, temporary prosthesis goes in. I evaluate form, function, and phonetics over the 3 or 4 months that I'm waiting for osseointegration to occur. See the patient back for a torque test. Everything looks good, feels good, sounds good, functions good. Off to the dentist they go, and we actually go to their office, and we will help them do photogrammetry to scan and restore the case. So we try to provide a little added service in that regard. But I've actually gotten criticized by Facebook groups for doing temporary crowns on implants because I'm an oral surgeon. And I do think that people tend to forget that I am a dentist. I did go to dental school. I do understand occlusion. I know what a functional cusp is and working side. And all, I know what that stuff is, man.
Yeah. If I can push back on that, because if you don't mind, Rob, I'm a restorative dentist, and I can certainly respect the fact that you're a general dentist, but I can tell you, 25 years of restorative, you learn a few things, and you learn, what to do, what not to do, how to. There's a whole world there too, right?
Yeah, absolutely.
And so I get the idea. And maybe prosthodontist would be a great conversation to have in this surgical, non-surgical discussion of, where, when, and how, and why would I do the prosthetic side, the fixed side? I can tell you that there are oral surgeons that are bringing in-house labs into their businesses to. I mean, just think about where we were. I mean, I graduated 2001. I mean, none of this stuff was happening. And now it's just like, it's a whole different platform, i.e. State of the Union and dentistry discussion today is like the landscape of dentistry is drastically changed.
Yes.
Yeah.
And the referral source is broken. The every quarter study groups from specialists are now becoming less and less commonplace because there are less referrals coming in of value for you guys. The specialists are getting into doing their own prosthetics and doing their own, having their own in-house lab. I mean, it's crazy what's happening. And at the end of it, the patient is the one that's maybe forgotten because, the GP does 1 in 16 and passes on 17 and 32 to you. And who cares about the patient? Let them suffer with local anesthetic for 1 in 16 where they could have slept through, you know, half the time to have all 4 extracted with maybe better healing. I don't know. And then you get these young dentists that are coming in with heavy debt that are almost feel like they're forced into doing these all-on X's and implant cases and go beyond their clinical setting and training to pay the bills, to get the job. I mean, these corporate guys, doesn't matter if you know how to place it well, if you just place the implant somewhere into bone, you have a better chance of getting hired than somebody that says, I don't place implants.
Yeah.
Yeah. What do you think, Jason?
Yeah, I was going to say one thing about like what Rob said is I do like the idea of you mentioned temporizing just to control the gingival contours. I can't tell you how many times I've placed an implant and then, you know, sent them off and I see them back later for a follow-up and their tissue's horrible. And it's just because whatever temporary got slapped in there is not appropriate for the gingival health. And then you've got this just ugly gingiva that they're dealing with. So yeah, I think that's great. But yeah, back to your, comment about, well, actually, if you could rephrase that real quick, I kind of lost track there a little bit.
Yeah,
about
I mean,
it,
just
but
talking about the landscape of dentistry today compared to 10, 15 years ago.
Oh yeah,
there's a lot more.
I was going to say, especially with the digital workflows and the fact that, you know, people have either in-house lab or the ability to just mill, you know, crowns or restorations in-house. You know, taking the lab completely out of the picture is another big thing, because again, those lab guys are smart. They know stuff. They see those impressions coming in, or, you know, the work that's coming in, and have their own input to place to that. And I really think that that's also getting lost, you know, losing that ability to have another set of eyes on those restorative cases.
Yeah, I'll tell you that the day that I started doing temporary crowns is the day that I became a better surgeon for implants, because I started to understand why there can be problems. Why can it be difficult to take an impression? What can make it difficult to take a scan on an implant? Boy, very eye-opening when we were doing stock abutments, which we just don't really do stock abutments with cemented crowns anymore, but you know, switching over to screw retained crowns, and just the trajectory of the implant in the anterior aesthetic zone and the nuances of that, very important. The nuances of occlusion, and the robot has really, I think, taken that to a new level as far as my ability to kind of predict a little bit, and understand better what kind of outcome we're going to get. And, you know, another thing I've noticed too is, although we still deal with and have a lot of corporate offices, I get a sense, and I think we may have touched on this before, but that I'm not saying that bubble is bursting, because I don't think it is, but there's definitely something happening. The pendulum is beginning to swing.
Yeah.
And I'm thankfully seeing a lot of young dentists, not a lot, but a few, that are doing what I was hoping more would do, and that is starting a boutique practice that really hones in on being a fantastic restorative doctor. And we have the good fortune to work with a number of those. And Jason, you mentioned digital workflow. That, in addition to robotics, is kind of forcing the issue a little bit of collaboration, and also laboratories that are all digital now. I love the way we do all on X. I think it's fantastic. It's all digital. There's not a single impression taken. We collaborate with our restorative doctors and our lab technician, and we get great results. And there are a few practices in the city that are really embracing that, and it's really good to see that. It feels great to put those temporary devices in place and then see them go off and get a fantastic product at the end of the whole thing.
Dr. Ryan Kazemi was on, and he said something that really resonated with what you're saying right now, Rob, which is execution. Execution and peri-implantitis being a huge problem in lack of execution in planning, implant placement, and you know, the end point of where you're going before you start, right? And he thought, and he mentioned very nicely about, you know, 3D technology, guided surgery. And I think you're alluding to that with robotics being guided surgery in so many ways, right?
Sure.
And I think, and we're going to have this conversation too, hopefully soon, about affordability of, you know, and practice like Jason's or like a general dentist who is in network with XNav and Yomi, and affordability of having these types of technologies and robots in practices. I think that's a great conversation that we're hopefully going to have soon on the live show. But I can also tell you there's the old guys that have been, you know, learned to freehand dentist implants, and that ego of freehanding and that skill, if I can put that in quotes, right, of being a surgical implantologist is also there. And there's a vast group of those doctors that feel like, you know, I'd rather have full control. And what if the guide is off, or what if the scan is off, or what if, you know, the robot runs out of battery? I mean, I don't know. You know what I mean? There's what if. You got to know how to freehand this stuff in the game. If you don't know how to freehand and you're so dependent on these robots and this guided surgery, now you're stuck. So what do you think about freehanding and making sure that you know how to freehand this stuff? How accurate and how likely is it that you have to abort surgery if you're going guided or robotics?
I think it's very likely to happen if you're using a static guide. Let me put it to you this way. I'll say it like this instead. Static guides are not going to be as good as you would like them to be a great majority of the time. Most of the time, they're within restorability, I would say, meaning they're going to put the implant in a place that is going to make it able to be restored. But you're not maybe going to be completely thrilled with it. And so then you have to ask the question, am I going to accept the guide placement, or am I going to now freehand it? Or am I going to abort the case and redo the guide and come back again another day? None of those choices are fantastic, but that is reality. I suppose if you have a lot of experience placing implants freehand, I would have no problem doing that. The question becomes, though, how do you get there as a new implantologist? Because if you have the technology available, are you really going to elect to train yourself to do freehand over an X number of months or years and then switch over to, no, you're not. You are going to start out with the technology that's available, which means if you're a new implantologist, unless you're just completely ignoring the available technology and just doing them all freehand, you're really never going to get that experience. And I'm not sure that you need, I'm not necessarily, I'm not really on that train that you have to be great at freehand, because I think you can just stop the case and come back and do it again another day. You know, we're not doing heart transplants. We're not doing bypass surgery. It is inconvenient. No one's going to be happy about it if you abandon the case and come back. But if it means doing the right thing, you know.
What are your thoughts, Jason? Looks like we lost Jason for a second. We'll come back to him. That's the beauty of live stream. I think Rob, actually, was it one time that we lost you too? No, you had surgery you got stuck
I had a
into.
surgery that went
Yeah, we
overtime,
started
yeah.
before. Yeah, that's funny.
Yeah. Yeah.
Well, I wanted to, we had this conversation, Rob, about how I have been banned from all these Facebook groups because of my because of my raw conversations. Go figure.
Man, it's soft. That is just so soft. And I'll tell you, look, that's another problem is, boy, now I'm going to start sounding very old right now. What I'm about to say is going to sound very old. But there's this thing on social media, and you see it like on Facebook. If you have a differing opinion about something, the first thing people jump at is, oh, you need to block this person. Why?
Yeah.
Why are you blocking someone because they disagree with you? Should we not want disagreement? We should want friction. That's how we grow, is friction. And that's the whole purpose of these forums, is to experience friction and disagreement. And it doesn't always feel great, and it's not supposed to, nor should it. Otherwise, what growth are you experiencing? You're actually regressing, in my opinion, by doing so. I don't like it.
Well, let's go back to Jason. Thanks, Jason, for not.
Yeah, sorry, I don't know what happened there.
Thanks for just not leaving the show. Okay,
Yeah,
coming back is like, screw this, I'm done, I'm out.
I don't know if my Wi-Fi dropped connection for a minute there, but
yeah, no worries. Go ahead. Finish your thought, then we're going to come back to this.
All I was saying is that, I think if you already have, and like Rob was saying, I think if you have that prior experience of doing things freehand, you already kind of know if you're in the right spot or not, whether the guide's telling you to be there or not, and you can self-correct or at least know where you're going. As opposed to, if you didn't have that experience, you might just blindly just be following the guide or the robot and end up not in the right place and have no knowledge that you're not in the right place because you don't have that skill set to know that you're there or not.
Yeah, I agree.
Yeah. So it's I mean, I'm just intrigued by all of it. I'm intrigued by all of it. By the way, as you all know, we're live and we're getting comments. And in regards to our earlier conversation about the ASC locations, they do not need to be owned by physicians. They could be privately owned as well. That's what one of the commentators mentioned. So I appreciate that.
I do feel like even if they're privately owned, I think they still have to have someone that's like considered a medical director or someone that's licensed, that's calling the shots or running it.
Yeah, here it says there are ASCs do not need to be physician owned. Many corps like HCA own them. I don't know what HCA stands for. But
oh, okay. Well, they own a lot of healthcare facilities.
Yeah.
So yeah.
Okay. Yeah, I don't know who they are, but so now let's finish, because we can continue to talk. I asked these guys if they have restrictions, and I'm like going to take advantage. No, I'm not. We'll come to an end, gentlemen. But this is actually, I think, how Jason and I kind of connected also on social, because he always made fun of my posts, and I
love your posts. But again, I compared them to fortune cookies. It was like every time I opened my Facebook and I saw one of those things, it was like I had to throw the little in bed at the end of it.
Yes.
Funny.
Some of them were, I mean, most of them actually were justified. I mean, I guess we can. So I had these for those that don't know, I for a couple of years I've been posting, and I've changed it recently, but they were red and black colored kind of short statements. And I was talking to Rob prior of how this live show all came about. It came about because I was not going to be silenced, gentlemen. And so I said, you know what? I'm going to create my own show, and I'm going to explain what these posts mean. So what I'd like to do is put some of them up in our brand colors. Now they're not going to be, I should have guys just left them in black and red, but so I'm going to bring these up random. I posted these, just you gentlemen know, I posted these on a regular basis every single day. I have hundreds of them in my diary of things that I can pull out of my cowboy hat, no pun intended. But we're just going to go through these. So they're going to be kind of quick. We'll finish with this. I think we have like 6 or 7 of them. Tori, why don't you put up the first one? So placing implants, onesies and twosies, does not qualify you for doing all on X. And I don't know if I got that much heat for that, but I'm LVI trained on the restorative side. If you want to bring back the doctors, Tori. And what we were finding, being LVI trained on the restorative side, is you do an 8-unit smile makeover, and it was a curriculum that you had to go through to get to full mouth rehab, opening verticals and doing more complicated services. And so the doctor would come do the 8-unit smile makeover and then would go home and do full mouth rehab, open verticals, and fuck everything up. Right. And so this discussion of why I posted this is to say, listen, your onesies and twosies are not all on X.
Yeah, I think that's true.
Yeah, I would agree. Yeah.
And like I said, I think I said this last show was, I'm not suggesting any particular type of doctor should or shouldn't be doing all on X, whether general dentist, prosthodontist, periodontist, oral surgeon. I know oral surgeons and they're fabulous friends of mine, but I would never let them do all on X on me. And I know a couple of general dentists and I would let them do it on me.
Yeah.
It's a matter of what is your training and how do you do them?
Well, you just have to understand the mechanics and the biologic, implications of things. You can't, and if you don't have respect for that, it's going to fail. There's going to be a problem.
Yeah.
We had Dr. Pere on, general dentist, was on with Rob, and he does beautiful all on X cases, and very, very impressive, very high level. There's general dentists, it's fair to say, that do amazing surgeries when it comes to pterygoids and zygotes, and they have amazing abilities to do revisions on surgical cases that specialists have done. But there are a few of those. There are not that many of them. I mean, there are very few of them, and we have to make sure that we don't magnify it to say they're everywhere. They're not. They're very specialized.
That's social media that does that,
Yeah, for sure. All right, Tori, next one. All right, well, maybe this will stir up some controversy. What do you guys think? Is it a sales pitch? I mean, are we doing too many all on X cases? Are we pulling too many teeth? Yes. Are we not restoratively respecting the possibilities of what moderate periodontal disease is and how it could be managed? Have we forgotten about the ability for endodontic treatment to be able to save a very highly infected tooth? Yeah, so that's kind of where my mindset was on. There are so many general dentists right now, for whatever reason, mostly sales, production numbers, and getting into multiple arches a month. And I think there's a balance. I think we're over aggressive. What do you guys think?
So I was going to say, one, I really always urge my patients to save whatever they can save. So, even if it's a couple teeth, if they can save teeth, save those. If that means they're doing some kind of locator, retain something, or even something removable, I'm going to tell them to save whatever they can save. The other thing is saving bone. I really believe in saving bone. And I think once you go to the all on X and you're removing, you have to reduce a certain amount of bone to have all the width for all the components. You don't get that back. And so, some of these patients are in their 30s or 40s and they're going for that treatment. And what happens when they're 50, 60, 70 and there's no bone left? There's really not any more options. So again, I'm all about saving the teeth and saving the bone. And, that all on X could be something that you get to eventually. but there's got to be some other more conservative ways, at least for some of the patients. I'm not saying everyone. There's obviously some candidates who that is the treatment that they need, but I think you really should try to preserve what you can.
Yeah, and I think FP1, when it comes to all on X, is overlooked by a lot of mostly implant centers.
Mm-hmm.
It's overlooked because it's difficult.
Yep.
And it's difficult because you have to have patience and skill to execute it properly. And sometimes it's not fast, and therefore it's not necessarily efficient. So they disregard it.
Mm-hmm.
And, that's one way to do all on X and preserve bone is to do an FP1.
Yeah.
Yeah. I mean, the sinus lifts have basically been obsolete in these practices. I mean, they're going, obviously I understand the cantilever idea, but they're going pterygoids just to bypass and not have the cantilever, making it potentially a lot more of a complex, complicated surgery where they don't want to, they want to get that PMMA in same day. And if you want to do that with the way you're set up with your in-house lab and your digital guide and all the investments that you've made, you got to get that production that day and get the patient in a PMMA. Why wait 6 to 9 months and do the sinus lift?
Mm-hmm.
These are the kind of discussions that get me banned from these private groups. But right? I mean, legitimate. What's wrong with the sinus lift? And so one general dentist said, sinus lift, the bone quality is terrible.
Oh,
And so you can't get a torque.
That's crazy.
And yeah, and the other discussion, which I can understand as far as moderate periodontal disease, they have more bone now, and they're already losing bone. And in 10 years, they'll have less bone. So let's just use that bone so we can place, right? I mean, these are the kinds of things that drive me nuts because you know what? At the end of the day, it's about the patient.
Mm-hmm.
And what I believe is that diagnostically, we push the patient in a direction that we want to push the patient in.
No question. I saw a lady 2 weeks ago that she said, she started out by telling me you're the third opinion. And I went all on X and I looked at her CT scan, and she probably had 40% bone loss on all of her teeth. And she had the vast majority of it. I think she was probably 1 through 30, or I'm sorry, 2 through 31 she had, and maybe missing a bicuspid here or there. And so I looked in her mouth. She's one of those patients that had periodontitis. It's now arrested. She does not have gingivitis. She has recession. Her teeth are not mobile. And I said, I'm not taking any of your teeth out, period. And she had 2 treatment plans for all on X, upper and lower. And I thought, what a crock. First of all, malpractice, in my opinion, and a crock.
Yeah, you made a point in one of the past shows where you said if you're doing more than 40 arches, you're overtreating.
Oh, yeah. There's not that many out there.
Yeah, and I would push that even to say if you're doing over 25 arches a month, you're overtreating your cases. Tori, next one. All right, I know you guys are going to jump on this one.
Rob, I'll defer to you on this one because I stopped doing orthognathic surgery. God, I don't know. It's probably been a decade ago at this point. And it was really because the hospitals that I'm credentialed at, I thought in the perioperative setting, I thought my patients were not getting the service they needed. Yeah. And again, I trained at Ohio State. So, I was really used to those nurses at Ohio State knew those procedures. They knew the postoperative care, and those patients had great outcomes. Mm-hmm. I will tell you that some of the hospitals that I'm credentialed at, when I did orthognathic surgeries, everything went great in the OR. You had the different nurses or other anesthesiologists that would pop in and be like, we haven't seen one of these done in 15 years. I wanted to pop in and take a look at what you're doing. and they're just startled by it, especially a Le Fort. I mean, people really lose it when you're cutting the whole maxilla off and moving it somewhere. But it was the post-operative care that they, again, nursing staff didn't know how to deal with somebody being tightly rubber banded, or, just the monitoring of vital signs whenever they're, recovering from that. There's all that concern about airway swelling, and they don't understand that all that swelling is happening in the face and it has nothing to do with the airway.
Right.
Just a lot of just bad experiences. So I stopped doing it. So I would say that I don't have the experience of seeing what these cases look like coming in from the orthodontist. But I definitely do get some that still come through that, I have to tell them that I don't do that surgery anymore, and kind of direct them towards the university, because they truly are a skeletal problem, and it needs to be treated skeletally.
Yeah, I love doing orthognathic surgery. I revel in it. I sit in church and look around and think, well, golly, geez, I think you need it. You probably need it. Man, you really need
80% in church need it. Right, that's right.
No, really. So I guess I'll just say this. When you say necessary, sure. Okay, I'll go along with necessary. Is it necessary? Nothing's necessary. I was born in West Virginia. You don't even need teeth, actually, apparently. But I can say that because I was born there. But yeah, I mean, I know what that means when I read that. But when you look at form, function, and phonetics, when you look at airway and skeletal problems, and also you look at social stigma associated with certain facial forms, and the patient comes and says, I want it, then they need it, period. That's period. That's it. And, I have to justify these cases to insurance companies. I'm not a provider for any medical insurance companies, but I still have to get the patient approved by their insurance companies so that their hospitalization is taken care of. And they have criteria that you have to meet. And so I would argue against that statement, because if I can convince an insurance company that it's necessary, you better believe that it's necessary, because they are in the business, insurance companies, of two things that insurance companies are in the business of doing. One, collecting premiums, and two, denying coverage. That is their business model. And so if I'm getting people approved for it, then I think it's probably necessary. Again, airway is huge. I spend every day talking about airway to someone at least once. And it typically is, someone coming in for a TMJ consult, or a jaw surgery consult, or something like that. It ultimately always comes back. 10 years ago, I never talked about it. Now I talk about it every day.
This would be another show, because I really think that there is a group of orthodontists, I'll use the word progressive orthodontists if I can, that are heavy into appliance therapy. And there is also a group, I can tell you, that are neuromuscularly trained, that are heavy into bringing the lower jaw down and forward. And I've done that multiple times in my career. And the discussion about the position of the condyle and the position of the suture, expansion, tipping, some of these appliances, and I'll show you guys some photos of what the possibilities are with some of these appliances. I do my own, and this is why I brought this up. I do my own orthodontics. I'm not an orthodontist. And I found, this is another discussion and an argument that could come up as far as relapse, right? In these cases, how stable are they once you get to that endpoint?
Yeah, well, that's why I rarely do a single jaw. I like 99% of the patients, I do a double jaw. Because for that reason, well, mainly because they need it. And it's a much more stable procedure.
Yeah. And so that's why I posted that, because there is, there's that school that says, if you are doing appliance therapy, and if you are bringing the lower jaw down and forward, and if you're able to create stability and not have the relapse, it's a great conversation, but that's why I brought it up. Tori, next one. Yeah, so I think we kind of covered that, Rob, on one of our last shows. But yeah, I mean, at some level, I think, why should you guys take on other people's complications? Why should you have to deal with the root tip and the sinus? Why should you have to? Now I get it. I get it. You know, you got 5 millimeters of bone. You're trying to do something.
Yeah.
Implant goes into the sinus. I get it. I understand. And, you know, at the end of the day, let's be
Definitely
real.
happens.
Also, like, you know, it's a practice of dentistry, right? So in fairness, you know, we all have to go through the practice to learn to be good and efficient and fast and predictable. So there's that side of it as well, to say, well, how did you get that good? We have to practice. So, you know, we have to keep that in mind. But I also think that there's a responsibility for certain things that are a little bit more clear and taking risk. And I think a lot of times it has to do with debt, production, money, leverage, payroll, paying the bills, not living paycheck to paycheck, having your wife or husband yell at you at home, you know, not being able to go on those vacations. And, you know, I think that plays a role in doctors' diagnostic skills and decisions.
Yeah.
And I think that's more common, and that's why Jason's getting the C's and D referrals today, versus the A's and B's that you probably got 10, 15 years ago. So that's why I brought that up. And I can tell you, endodontists that I've spoken with privately would tell me that they're getting, on a regular basis, potentially 50, 60 separated files a month in their practices from GPs trying to do endo file separates mid-root, and now they're ending up in their practice. So I'm intrigued by that. Tori, next one. But I didn't get to, I mean, I don't read that fast, but geez, Tori.
What was the last one?
Yeah. Can you put that back up? Yeah. So I had one of the, and I'm sure at some level they were being sarcastic, but one of the implantologists who has placed thousands of implants, he reminded me during that conversation on social that he's never had an implant fail. It's always the biology of the patient. Either they're smokers, or they have some autoimmune problem, or they had some history of cancer, or God knows what. What do you guys think? What do you guys think? Do implants actually fail?
We've all had failures. So, and you know, that's the thing is, yeah, implants can fail. And again, there's reasons they fail. So it could be patient selection. It could be the surgical procedure. It could be, you know, a whole host of other things with their biology. But yeah, implants can fail, and you learn from your failures and move on, and hopefully have less of them. But yeah, I would never say that I've never had a failure.
Well, and we can say what we want, but whatever the patient believes,
Yeah.
or whatever the referring doctor believes, that is reality. And typically it is on your shoulders. And there's a big period at the end of that sentence.
Yeah.
Yeah. We just had a video go viral yesterday and today, and it's still hot on Instagram, about implants and the type of implant that you have and the decisions you have to make with what implant you choose to do all-on-X surgeries. And this particular doctor, had over 25 all-on-X cases that he had to redo because his Megagen implants that he was placing at the time were failing on him. So you guys can see that video. Go ahead, Tori, next one. It should actually say DMD, JD, MD, DMD. I don't know, whichever way you guys, you know, put your initials. But what do you guys think? Who's more powerful, man? You guys or the lawyers that?
Well, I'm a single degree guy, so
Yeah.
But I think what you're asking here is, Well, I mean, what's the most powerful? I guess it depends on what you're wanting to do, really. I've never viewed there to be a tremendous advantage of having a dual degree in oral and maxillofacial surgery. I applied to one program that was dual degree, and I didn't rank it after I went there. It doesn't broaden the scope of your practice at all. You miss out on 2 years of potential income, and you pay 2 years of tuition. So financially, it's not a great decision. And then the argument is, well, yeah, but if you want to go into academics, it helps you. It does not help you. Trust me, if I wanted to go into academics, I would have a job tomorrow. Like literally, I could have a job tomorrow in academics as an oral surgeon. Nobody wants to do it. I don't know.
That's interesting. I didn't really, dig into that mindset of a single versus a dual degree.
Yeah, about half
so
the program.
So you don't think going to an additional 2 years and getting you go to medical school. So that's what you guys wanted to do in the first place anyways. And you
go
didn't
to
get
the last
accepted.
2 years of medical school. You basically do years 3 and 4 of medical school. So, I mean, you're walking around in the hospital doing rotations is what you're doing. And you're paying tuition for 2 years.
Yeah.
And you're missing out on income for 2 years. And I just have to scratch my head, and it's cool. I think it's cool, but is it helpful? I don't think so.
Yeah, Rob, I'm like you. I'm single degree from Ohio State. They did not have an MD track. Again, coming off of my failed attempt to be an orthodontist, I applied to 24 schools and I got 23 interviews. And University of South Carolina was the one school that did not offer me an interview. But yeah, I think I had a couple in there. There was maybe like 2 or 3 that were MD programs that I checked out and did not rank them very high for the exact same reasons that you mentioned. Losing the 2 years and also paying tuition while doing it. After interviewing all those schools and looking at what the different programs had to offer in terms of the breadth of experience, I just didn't think that it was worth it.
So would it not be, and just thinking out loud here, would it not mean that you're more into sedation and more in OR and doing, more traumatic type, car accidents, and it doesn't mean any of that. So it really has no value is what you two single.
I wouldn't say it's no value.
Yeah, I wouldn't go that far. I don't think I'd go that far. It's cool. I think it's interesting. If you wanted to do like a cancer head and neck fellowship, then okay, now we're into a situation where that's going to be helpful for you. Or if
craniofacial.
Yeah.
Doing craniofacial, like neonatal craniofacial.
Yeah. If you're doing the stuff that we do, and by the way, you mentioned car. I've done all that stuff. I mean, I've done bicoronal flaps. I do orbits, maxillas, noses, frontal sinus. There's no increased scope of practice at all. None.
Yeah, I would say the scope of, especially if you get into trauma and reconstruction and those kind of things. I mean, there are some of the 4-year programs. Again, it's going to depend on the particular hospital and what agreement they have with the other services that cover the facial trauma. So some of those places, the oral surgeons are the only ones that cover it. So they're getting a lot of experience, between sharing it between ENT and plastics.
Mm-hmm.
I should have changed that post, and actually I should change that post to say single degree oral maxillofacial surgeons and dual degree.
You'll get friction there for sure. Yeah. But like in Oklahoma City, the oral and maxillofacial guys are the only ones that really do facial trauma. Nobody plastics. They do at the university. Now that's different. Jason brings up a very, very valid point in that there is competition in academic programs for doing facial trauma. I know certain programs that I think Cincinnati was like this. They actually sent their residents to Knoxville.
Yes, I think
to get trauma training because they were limited in their own program by the other services, which basically said, we are doing mid-face trauma and you, the oral surgeons, may not do so. So that's very unfortunate.
Now that you mentioned that, I do think I remember when I was interviewing places, there were some programs that I went to where they would say, we treat the mandibles, and then, someone else treats the maxilla or the orbits, like mid-face.
Yeah.
I would say at Ohio State, and again, I don't know how much it's changed, because again, that's 20 years ago to me. It was almost like we fought over who didn't have to handle it. Some of the other services were real quick to say, like, why don't you guys do it? You guys are good at it. You should do it. And
we got a lot of
send it to us.
Yeah.
Which brings up the next topic of facial plastic surgery, and you guys getting into 1 year of plastic surgery and start doing, rhinoplasties and all the other stuff.
I never had any interest in that stuff, but I know I've got some friends that do, and they do a great job of it. I think it's well within the scope of practice of an oral maxillofacial surgeon to do any of that stuff. As long as, again, you have to have the training, though, like legitimate training, and have the caseload. And then, of course.
And you're going to get some pushbacks from plastic surgeons on that too, right?
I would fully expect that. I would 100%. I would think they're crazy if they didn't push back. It's a financial competitor. Obviously, we should push back.
I have to say, it's not very often that I'm the third best looking guy on the screen. I have to just kind of, bow to the good looking guys on this screen, man.
It's the it's the hat.
That's right.
It's my lighting. That's it.
No. Gentlemen, I appreciate you guys being here. By the way, there was a question on Instagram. How long is your average consultation for Airway? Under or over 20 minutes?
Oh, Airway, probably. No, okay. It's longer than it has to be, because I get on I love talking about it.
It's important.
I find so strange that I have this obsession with it, but it's probably 30 minutes. And I love teaching. I was on staff at the university for about 10 years in the beginning of my career. I was still in private practice, but I would go down. So teaching has always been kind of one of my passions, I guess. And I kind of hate that word, but and you can just see, like, when you start talking about it, you can tell this person has never had anyone tell them any of what I'm telling them right now. And you just start seeing the lights come on and the dots getting connected. And you say, I ask them, do you snore? And they always say, well, I don't know. And I said, well, let me talk to you about snoring. And I talked to them about the airway and about hypoxia and acidosis and sleep cycles and the adrenal glands and epinephrine and arrhythmias and hypertension and gastric reflux and type 2 diabetes. And it's like, they're just like, their eyes are getting this big. And I get the same thing every single time. They say, thank you so much for teaching me that. And by the time they leave here, they've generally decided that they're going to download a sleep app to monitor their sleeping. A lot of them will go and get a sleep appliance to prevent themselves from snoring, or at least go get a sleep study to check to see if I would love to do a show about sleep. We need to do that.
Yeah. If
Rob,
Jason,
Rob, do you treat sleep apnea, or are like?
I do. Mostly with a maxillomandibular advancement.
Okay,
I just did a case 2 weeks ago, and I mean, it is phenomenal. The guy, I went in to see him the next morning, and he was literally laying on his back in the hospital. Now his head is elevated 30 degrees, right?
Right.
But he's laying on his back with no CPAP, breathing, not snoring, and his wife was just telling me, I can't believe what I'm looking at right now. It's astounding.
Well, yeah. If you look at the MMA compared to like doing some of the more ENT type stuff, like the UPPP and those other procedures, MMA is so much more likely to solve the problem.
Yeah. Yeah, but it does require a lot of education because we talked about relapse. How you relapse with sleep apnea is you gain more weight. And so there has to be a lot of effort put into this. And I talk to people about it quite a bit. I say, you know what? We may not get rid of your CPAP completely, but you know, you may get rid of it for several years, or you may be able to turn the settings down. But just taking someone from where they were when they came for the consultation, talking to them about weight loss, and I don't shy away from it. I get right into it in a really nice way because I myself was overweight significantly, so not too long ago. And so it's easy for me to talk about, and it's just, so yes, 30 minutes is the answer to the question.
Ozempic, gentlemen, Ozempic, lost weight.
Yes.
Lose weight with Ozempic. Come on. Right?
Well, I mean, you know, if you're 600 pounds, 300 pounds. Yeah. I know it's not a popular in some circles, but the alternative is also not healthy. Yeah. And again, education and commitment to processes is important.
Just so you know, forget about Virginia. In Oklahoma is the only place you find people that are 600 pounds. You don't. I'm totally joking. What about you, Jason? Plus or minus 20 minutes?
So I don't treat sleep. So
interesting.
I don't have an answer for that one.
Okay.
Yeah.
Interesting. I treat sleep apnea with mandibular advancement appliances.
I wear one at nighttime, by the way.
Do you?
I do.
Which one?
I wear Snore RX, actually. I got it online, and it is a life changer. I do not go to sleep without it, period.
Has it changed your occlusion?
It does for about an hour when I wake up.
Okay, but it's not it hasn't permanently changed your occlusion.
No, I mean, if I want to occlude, if I don't do anything about it during the day, yeah, I mean, I'm a little more class 3. But if I just kind of take an hour to sort of work on it, it goes back. And you know what? I'm happy to be class 3. If I don't snore and I don't have reflux and I get a good night's sleep and I feel fantastic when I wake up, okay, sure, I'm class 3. Great.
Yeah. Yeah, that's a great conversation. I mean, there's so many conversations we can have around this kind of stuff.
This is a great topic.
Yeah. Jason, what's next for you, man? You're going to shave that beard and we can see that good looking face of yours, or
what?
You know,
I don't know. You know, it's interesting. I can't think if it was like 2016, 17. I grew a beard for the first time, and it was like at Halloween time. I think I had a plan. I can't remember what I wanted to be, but I grew it for Halloween. And then of course November came and it was no shave November, so I kept it. And then I had a couple of years where I'd shave it off after November, and then I'd regrow it again. And I think around, like, honestly, I hate to say it was COVID, but around like COVID time, I was, you know, when they started making you wear masks and saying they have to be fitted to your face. And I was like, I'm not doing this. Screw this. So I grew the beard to fight against the N95s. I just wasn't going to wear one. And I've kept it ever since.
I will tell you, a smooth face is much better in bed. So
no, I don't know. I'm hearing opposite on that one.
Are you? Okay. All right. Fair enough. Rob, I know you got an event coming up. Talk to us a little bit about it.
Yeah. So I started the American Academy of Robotic and Digital Dentistry about, a year ago is when I founded it. We haven't had our first meeting yet. That's going to be this September 18th and 19th in Oklahoma City. Dr. Alessandro Pazzi from Rome, Italy will be here talking about digital workflow. Jay Newgarten, who is a fantastic oral and maxillofacial surgeon in New York City, will be here with his restorative partner. Alessandro will be speaking on Friday. Jay and his partner and Andrew Johnson will be speaking on Saturday. It'll be 12 credit hours. It's about $1,200. It's at a fabulous hotel. There's going to be great food. We're going to have a try-it room with photogrammetry, with scanners. The robot's going to be there. I think XNAV is going to be there. Implant companies are going to be there. My executive director is Dr. Mike Fling, who's the former president of the American Academy of Restorative Dentistry. My hope is that we can form the goal and purpose of the Academy is to form a nucleus of like-minded people that can really push the agenda for robotic dentistry. And besides that, implants, that is, robots are going to be used for crown preps, fillings, endodontic access, corrective jaw surgery, and it's coming. And so we want to be at the forefront of it. This is a whole nother topic, and I'm sorry to bring it up, but we talked about it last time. The 3D printed guides are great, but we're already into technology that's beyond that. And so it's not antiquated. I don't want to go that far with it, but we are forward thinking here. And if you are going to be a forward thinking implantologist, if you think you're a forward thinker, you have to be at this course. You have to come to this course, because that's the kind of people that are going to be here. So September 18th and 19th, we have a website. We've got, it's the AARD.com, the American Academy of Robotic and Digital Dentistry. Look it up and get signed up for the course, because it is going to be a banger.
Rob, you're selling me on it, because I got your invite, and honestly, I've done a lot of CE already this year, and it's only May, so I was tempted to not go, but now I'm thinking I need to be there.
It's going to be great. I mean, it's just one. And by the way, Oklahoma City is a fantastic city. I love living here. I didn't plan on living here. I moved here just because I got my residency here, but I mean, it is well, by the way, basketball is great too. I don't know if you've noticed or not, but we have a pretty good basketball team here.
Yes.
Yes.
Yes. I mean, that's all you got in Oklahoma City is a basketball
I don't
team,
know,
right?
man. Give it a try. Give it. I do love the fact that it's a flyover state. You know, it's a nice gem. It's a nice little gem, hidden gem here.
Well, gentlemen, thank you. I want to thank both of you for coming on. Jason, thank you for accepting my invitation.
Yeah, thank you for having me.
Yeah, I appreciate you doing this. And it's great to have these conversations. I think, I learn a lot in these rooms, and it gets me thinking about what other shows I need to work on and bring in for the audience to listen to. So, gentlemen, thank you so much. Dr. Jason Yanich and Dr. Rob Bryan, board certified oral maxillofacial surgeons. I appreciate your time.
Thank you, sir, for having us.
Wow, that was we covered a lot of different topics today, and it was a great show. I appreciate them for being on. We try to do these shows in 1 hour, but there's just so much to talk about. So I don't know if we should put a restriction on these things, but anyways, next week we have Dr. Jason Olitsky. We're going to go from oral surgery and OR into no prep cosmetic dentistry. He has an educational program called Smile Stylist, and I'm excited to be talking to him. So come join us. Follow me as always at Dr. Shaheen Safarian on all the social channels. And until next time, I'm excited with what we got coming up. We have some amazing guests that are going to be coming on the show.